knock on the door. Hi, Mr. Logan. I'm Bailey. I'm going to be your nurse today, and I'm going to go ahead and do a head-to-toe assessment on you just to make sure everything looks good, or check you out real quick to see what's going on with you. Can you tell me your name and date of birth? All right, good. I'm also going to wash my hands, and then I put on clean gloves. So I'm going to check your ID band just to make sure each one matches. Okay. Okay, and I looked at my whiteboard. It's the correct names on the staff, with staff names and dates. Do you have any, let's see if you have any oxygen. No. Okay, any feeding tubes or NG tubes? No. Any abdominal tubes or wind drains? I do not see any. Okay, chest tubes, no chest tubes. Trach, let's see, a trach. Foley in, no Foley. Okay, and then you do, looks like you do have an IV running. Looks like it should be a normal saline at 250 milliliters an hour. Should be in your right arm. So I'm going to go and check that out. I'm going to look and see if I see any swelling, any tenderness, drainage, or redness. So everything looks good. I want to make sure my line is running and is connected to my pump and connected to my bag. It all looks good. Saline. We got normal saline, 250 milliliters running. And we got the label on it of when it was hung, the correct time, correct drug, correct dose, and correct route. Okay, now I'm going to see how many side rails. We got 2 side rails, and it is necessary. Make sure our bed is in low position. Your call light, make sure that's in reach. There's that. No obstacles at the bedside, none at the sink, none in the way to going to the bathroom. Got your assisted devices near. Got your water pitcher and cup right here. Okay, and also we're going to say this is your urinal as well, so that's at the bedside. You don't need a commode, but the commode that you do have is empty, and a trash bag at your bedside. Alright, so before I get into the head-to-toe assessment, since my patient is diagnosed with DKA, some of the signs and symptoms I might see are dehydration. They may have, I'm going to check their LOC because they may be in a coma. If I check their blood sugars, it can be anywhere from, it can be 250 to 300 or more. They may have a fruity or acetone breath. They can have goosemal respirations. Their blood pressure can be low. They may tell me that they're going to the bathroom frequently, and they can be thirsty. So, and then I can also look at their labs and see their potassium may be decreased, so that may cause any blurred visions, headaches, or weakness. Their sodium bicarb could be less than 15. Their pH could be anywhere from 7.3 or less. Their serum osmolarity can be 340 or more. Alright. Okay, so I'm going to go ahead and I'm going to look at your face. I just want to make sure everything looks symmetrical. Don't see any drooping. Okay, I'm going to check your vision. Can you look at my finger? Sides. Okay. Now I'm going to go ahead and feel your pulses bilaterally. Okay, now your pulses, got 87. They were weak and rapid. I'm gonna listen for the respiration, or look for the respirations. Yeah. Okay, and respirations were 32. They were very labored and deep, and there was an increase in the rate and depth. Okay, and then I would go ahead and check blood pressure. I would have my blood pressure cuff. And I'd be listening to that. Okay, and the blood pressure was 123/77, and your pulse ox was 96. When I was feeling for the pulses, I noted the skin as well, and it was warm and dry. Can I see your mucous membranes? Okay, they are dry. I'm going to check your skin turgor at your chest, pinch it. Skin turgor is poor. I'm going to go ahead and also check your cap refill. Okay, and then can you pull towards me, or push towards me, pull away from me, and then squeeze my hands, wiggle your fingers. Alright, so noted that your the arms were a little bit weak. Respirations. Listen to the respirations and have them breathe for me. Okay, so lung sounds sound good. Your respirations were, like I said, you breathing heavily. Also, I forgot to ask you, can you tell me where you're at today? Can you tell me your name? And you give me your date of birth. Okay. So my patient was alert and oriented ×2, a little bit drowsy. I also am going to listen now for your cardiac, or for your apical pulse. Okay, S1 and S2 sounds were heard. Alright, now check out your abdomen here. Are you having any pain or anything in your abdomen or in your upper extremities at all? Any tingling or numbness or anything? No? Okay. I'm going to palpate. I'm just going to feel, and if there's anywhere that's tender, you can just let me know. Right? And I'm just going to listen to those bowel sounds and all the quadrants. Okay. Can you tell me when your last bowel movement was? Okay. And are you having gas or belching or anything? Pretty good. Are you having any problems going to the bathroom or anything? Or how many tubes that I should know about? Right. So the abdomen was a little distended and rounded. The patient did complain of abdominal pain. There was distension, and they also came in complaining of nausea and vomiting. Alright, and then I'm just going to finish up. I'm going to check out your legs. I'm going to make sure you don't have any edema or anything. So I'm going to look at the legs. Okay, legs look good. I'm going to check out your feet. Can you push towards me with your feet and pull away from me? Wiggle your toes for me. Okay, and I'm going to check your capillary refill bilaterally. Okay, looks good. And I'm also going to check your pedal pulse. So, pulses. So we're able to feel or palpate the pulses in both the upper and lower extremities. And were you having any pain in your legs, any kind of tingling or numbness or anything? Okay. So I also want to note that the patient's upper extremities and their lower extremities were both a little weak. They weren't very strong. And then I'm also just going to go back in, and I just want to check since they do have an IV, I want to check your IV site. Make sure that there's no infiltration and that there's no swelling or tenderness or any kind of redness or drainage. And make sure that it's connected to my IV solution. And I want to double check that my solution matches what's on my order, which was 250 milliliters an hour of normal saline, is what's currently infusing. And then I'm also going to note that the glucose, I did take their glucose, and their glucose was was maxed out on the test. It was more than 450. Okay. So now that I've checked out my patient, I'm going, some of the treatments that we can give the patient for DKA is 0.9% normal saline through the IV at 500 to 1,000 cc's an hour for 2 to 3 hours. When their blood sugars reach that 250 range, you want to change it to 5% dextrose at 0.45% normal saline and give the potassium through the IV. And then you want to replace their potassium because their potassium levels won't be normal, and you would do that through IV. You also want to give regular insulin at the IV at a slow rate and 0.9% normal saline. Going too fast can cause cerebral edema or fluid overload in them. And you want to keep it in there, keep this saline running until the sodium bicarb reaches the range of 15 to 18. Okay. Now I'm going to go through my case study questions. Alright, so our patient came in with, he has type 1 diabetes and he was found by his family with a decreased LOC, rapid heavy breathing, and fruity breath. His family reports flu-like symptoms for the past few days. So before I gather any more information, I expected that the patient was having a DKA episode because of his rapid heavy breathing, which is a sign of Kussmaul respirations. Their decreased LOC, the family said that he had flu-like symptoms, so he could possibly have been mismanaging his sick day rules. And then they also says that he has fruity breath, and they're all symptoms of DKA. Diagnostic tests that I would expect to be ordered from the doctor is a CBC and basic metabolic panel, and also it's expect to check the serum ketones and their urine for any ketones or glucose. Their hematocrit, hemoglobin, bone creatinine will look increased because of the dehydration. Their serum and osmolarity will be increased. Their pH will be less than 7.3. Their blood sugars will be increased. Their potassium will be will be increased. Their sodium bicarb will be less than 15. So after the nurse does the metabolic panel and the arterial blood gas, found out the patient was oriented times 2 and drowsy, breathing heavily, lungs were clear. They had S1, S2 sounds present, bowel sounds were active, pulses were present times 4, and their glucose test reads over 450. Their vital signs, heart rate was 87, respirations 32, blood pressure 123/77, pulse ox of 96. Their lab results, their glucose was 804, potassium 6.1, bun 39, pH of 7.12, creatinine of 1.9, PCO of 30, anion gap of 29, and sodium bicarb of 17. and their urine was positive for ketones. So, the reason why Mr. Logan's glucose was at 804 was due to the patient. So due to the patient's high glucose level, it means that his body is producing enough is not producing enough insulin, and his body is releasing glucagon, which stimulates glucogenesis in the liver, and it starves the tissues. The urine is then also positive for ketones because the ketones or the tissue starvation and the buildup of the ketones or the product of that. So due to the tissues being starved, the product of that is the ketones are being released into the blood, which causes acidosis, and so you'll find ketones then you'll find a large amount of ketones. The reason that the BUN is at 39 and the potassium is at 6.1 is because of the high blood sugars, because this can cause a water loss, and it causes dehydration, which then increases the BUN and potassium levels. The pH of 7.12 is acidic because of the buildup of ketones in the body, which it also causes metabolic acidosis, and then it causes the blood to be acidic. The number one priority that we're going to take care of for Mr. Logan at this time is to replace his fluids through the IV, like I said, by giving a 0.9% normal sodium chloride at 500 to 1,000 cc's an hour for 2 to 3 hours. So after the provider writes an order for the insulin Lispro infusion IV titrating to decrease the blood glucose per protocol, 1 liter of normal saline bolus now, and continuous infusion of normal saline at 250 milliliters an hour, and to change to fluids to dextro or D5 half normal saline at 125 milliliters an hour once the blood glucose levels fall below 250. So the first action that you should take after receiving these orders, I put that you want to gather the equipment that you're going to need to make sure you check the blood sugars just to verify that they aren't below that 250 mark, and you want to administer that 1 liter of normal saline bolus right away to prevent the patient from more dehydration. So the provider adjusts the order to regular insulin IV fusion. Orders are also written for hourly glucose checks and every 2 hour BMP. Why is it important to check a BMP frequently, and what are we monitoring for? So it's important to check BMP frequently because we want to make sure the high levels are returning to normal, because that means the patient is no longer dehydrated, and we want to make sure that we aren't overhydrating them, because it can lead to fluid overload and can cause cerebral edema. So what we're going to monitor in that BMP is for an increase or decrease potassium, BUN, hematocrit, hemoglobin, blood sugars, especially blood sugars, sodium bicarb, and their pH. So after the 4 hours, another 1 liter bolus of normal saline. Mr. Logan's glucose levels have dropped to 174. His anion gap is still 19. The nurse changes his fluids. Then their most recent BMP showed a potassium of 3.7, down from 6.1. So the provider ordered he gives 40 milliequivalents of potassium chloride by mouth. So the insulin is why is the insulin continued even after the blood glucose is decreased? It's because the insulin is still continued even after blood glucose is within the normal limits, because if you stop the insulin, the ketones will increase and acidosis will reoccur. So another 4 hours goes by. Mr. Logan's anion gap is now 12, repeats the ABGs, shows pH is 7.36. Bicarb levels are normal. They've transitioned Mr. Logan off the IV infusion to sub-Q insulin. He feels better, says he's embarrassed. The education that we can provide Mr. Logan to help him understand and to prevent future episodes happening like this again. You can give education about sick management rules to help prevent future events like this. You can tell them to take their insulin or OHAs as normal, check their blood sugars and urine for ketones since he has diabetes type 1 every 3-4 hours. And if you have a hard time holding things down, and eating regular meals, he should substitute for things that he can easily digest and eat 6 to 8 times a day. If he has vomiting, diarrhea, fevers, he needs to take at least 8 to 12 ounces of fluids per hour and take them as sips, such as like with sodas, broth, or Gatorade, and then report to the PCP if he's having any vomiting, diarrhea, or nausea because of fluid loss. You can also explain that the reason that he may had a DKA episode was because of his body was decreasing in insulin because he was sick, wasn't feeling good, had flu-like symptoms. So that was like a stressor on the body. So like emotional, physical stress can cause it, such as him not feeling good or being sick, and then he could have mismanaged his 6-day rules by maybe he didn't feel good, so he didn't take his blood sugars, or maybe he wasn't taking his insulin, possibly. Alright.